Thank you very much. Well, we heard from multiple talks this morning about the importance of PSA and how to use it. We heard from Matt Cooperberg, start with a biomarker. We've just heard a deep dive into MRI. I think there's a third option that's extremely appealing, which I'm going to talk about. I've had research support from Exact Imaging. So why beyond MRI? Clearly, MRI is a game changer, powerful modality, but it has definite limitations. We've heard about variation in interpretation, the specialized training required. It requires fusion targeting, which involves another whole layer of technology and potential for error. There's artifacts from prior treatment and biopsy. It misses small lesions. Gadolinium is required for multiparametric. You can get cumulative toxicity. Some patients just can't have an MRI because of implants, claustrophobia, and so on. Cost can be an issue. There's a lot of parts of the world where access to MRI in a timely fashion is very challenging. So this introduces an alternative high-resolution micro-ultrasound. The key point is it's 29 megahertz compared to 6 to 9, plus higher crystal density. This confers 3 times higher resolution. And the key point is that alterations in prostatic ductal anatomy, the same principle that results in restricted diffusion on MRI, gives you a signal that you do not see with conventional ultrasound. And there's a relatively short learning curve for practitioners who are used to doing ultrasound. It looks like a conventional ultrasound device. This slide just compares conventional ultrasound to micro-ultrasound in the same patient, and there's a lesion here on the micro-ultrasound. These become readily apparent once you start doing this for a few months and not visible on conventional. So what is the data? Does it really perform comparable to MRI, and it's a high bar. So this is an early study that compared the first 11 sites that started using this MRI versus ultrasound. It was a registry, not everyone was blinded, so it's limited in terms of its quality, but it did show that the sensitivity compared to MRI was at least as good, if not a little better, and the specificity was about the same. So since then, there's been a number of better studies that involve blinding of the ultrasonographer to the prior MRI, and essentially these studies, 7 of them, all show the same thing, which was relatively comparable sensitivity and specificity to MRI. But of course, these were not randomized. And so now we have randomized data. This was published about a year ago in JAMA, the Optimum trial. So this is now level 1 data, a large-scale trial, 20 centers, 8 countries. This was basically men with an elevated PSA in whom a prostate biopsy was felt to be indicated. And the cohort was divided into 3 groups. Group 1 was micro-ultrasound alone. They all had systematic biopsies, so systematic plus targeted guided by micro-ultrasound. Group 2, the combination of MRI with micro-ultrasound, blinding to the MRI, systematic and targeted biopsy, and then another biopsy if there was a different MRI target after unblinding. And Group 3 had MRI and conventional fusion-targeted ultrasound. There was a 3 to 2 to 1 randomization cohort, the main idea being that, first of all, half the patients got micro-ultrasound and half got conventional ultrasound, but only a 1/6 of the patients were exposed to diagnosis with micro-ultrasound alone in case it turned out to be an inferior imaging modality. Only a relatively small group of patients would be at risk. And the randomization resulted in balance of major risk factors, PSA, DRE, family history, and so on. There was no significant imbalance. And here is the data. And essentially, the study showed that with respect to the accuracy, sensitivity of diagnosis of grade group 2 or higher prostate cancer, there was no difference. grade group 1, the micro-ultrasound only, 47% grade group 2 or higher, 25% grade group 3, and essentially the same proportion across the 3 groups. In fact, there was a 4.5% higher diagnosis rate with the micro-ultrasound compared to MRI with conventional fusion-targeted ultrasound, but non-inferiority was achieved with a very strong level of significance. And they had systematic plus targeted. This was planned at a time when systematic biopsy was unequivocally the standard of care. When you pull out the targeted biopsy only results, again, no difference. The rate of diagnosis with targeted only biopsy for grade group 2 and grade group 3 was essentially the same. Again, a somewhat higher diagnosis rate with micro-ultrasound compared to conventional, but this did not achieve significance. There was no difference in the rate of grade group 1 prostate cancer between the 3 arms, not surprising because they all had systematic biopsies. And the discordance rate was the same between the 2 groups. So 7% disease was only seen on micro-ultrasound, 7% was only seen on MRI. These are complementary technologies. Just a couple of other data sets that I think support the value of this technology. We've heard quite a bit at this meeting about the problem child of PIRADS3, do biopsy or not. Here is data that in the patients with PIRADS3 who had a negative micro-ultrasound, there was 100% negative predictive value for clinically significant prostate cancer. We've also heard some data at this meeting about PSMA, looks quite similar in the PIRADS3 and MRI negative setting, but the cost of micro-ultrasound is a fraction of the cost of PSMA in most regions. Volume assessment, here's some data showing that the under-assessment of volume that we know characterizes MRI is better with micro-ultrasound, a closer correlation between whole mount cancer volume and micro-ultrasound assessed cancer volume. So, you know, nothing is perfect. It has limitations. There's a learning curve. The onus is on the practitioner, who's typically a urologist, not a radiologist. You've got to get that mindset that you are evaluating the image, and the onus is on you to do a quality job and not rush it. There are cases that are missed that are found on the other imaging technology. Calcifications can obscure the anterior prostate. You have to be aware of that. And now, increasingly, we're moving to biparametric, so cost of MRI comes down. But the strengths are one-stop shopping. Patient comes in, imaging, and biopsy at the same time. Patients really like that aspect of it. Again, it avoids a lot of the problems associated with access to MRI and some of the pitfalls associated with fusion targeting. So to conclude, it's got a lot of appealing features, one-stop shopping, avoids some sources of error with fusion targeting. We have now level 1 data showing non-inferiority. It's quite inexpensive compared to MRI in many, if not most, regions of the world. There's no requirement for contrast. There's no specialized MR technologist required, and it's particularly appealing in those parts of the world where MRI resource is constrained. Thank you very much.